So I've been using Varithena in my practice for about 5 years. And I like to say that I was one of the early adopters in that not only was I able to utilize it in my patients, but I also was able to make all the mistakes. And so as I make the mistakes, I learned along the way. And I'm here today to make sure that I share with everybody what mistakes I made so that they don't have to necessarily do that. They can avoid these mistakes along the way. My evolution with Varithena is a very interesting journey. When I first was introduced to Varithena, it was introduced to me as 1% polydocanol injectable, which is exactly what it is. And I was confused because polydocanol has been around for many years in the form of physician compounded foam. So I wasn't very excited about it until there was more explanation about the uniformity of the bubbles and how important that is in the stability of the compound. Why the stability of the compound is so important is that the more compound that is available in the system, the better the wall contact of the medication and thereby better closure rates. I still didn't buy it. And so I started using it in my distal calf GSV patients initially. We all know that we're concerned about thermal injury, particularly in the distal calf. And so we shy away from using thermal modalities such as radiofrequency and laser. And I felt like in those situations, what I was doing was at that point using physician compounded foam, thereby it would avoid any type of potential injury. And so my answer was, I already use physician compounded foam in the distal calf GSVs. Why would I want to use Varithena instead? And so I did a little bit of a trial in my office in that I gave 10 patients, distal calf GSV refluxing patients that were symptomatic, physician compounded foam, which I typically was doing, and then the next 10 patients I gave Varithena and basically injected in the same fashion. And what I found was after following up with these patients months later is that my closure rates on the physician compounded foam side were not as good as I thought they would be. My closure rates were roughly about 60 to 70% in the distal calf GSV. So I was obviously taken aback by that because I thought my closure rates would be way higher. When I looked at my Varithena subset of patients, I found that the closure rates were above 95%. And I think that's when Varithena caught my attention. I said, this is for real. And again, it started to make more sense as I became a student of chemical ablation. One of the major things that I learned along the way is that you have to treat Varithena as a chemical ablation in that there's certain steps that need to be taken and maintained. There's certain protocols that should be followed in your practice. This is not just injecting a foam and calling it a day. This is making sure the proper patient is selected, making sure that patient has the proper positioning, making sure you have the adequate equipment to deliver the medication. So all of these things are very important, and it's a huge learning curve along the way. As I started to become more comfortable with using Varithena in the distal calf segments, I started to think about these patients that would come back years later that had recurrent symptoms. And you do the ultrasound, and you would find pockets of reflux in the patient's great saphenous vein. And then you'd say to yourself, well, the patient's symptomatic, they do have reflux. However, the vein has a lot of scarring on the inside of it because it's been previously treated. So it becomes very difficult to treat these patients with any type of thermal modality, as you can imagine. Trying to put a catheter or a fiber into a vein that has already been scarred down can be painful for the patient as well. So I decided, why not utilize Varithena in that particular scenario? As we know, it's liquid. And so liquid finds ways and crevices and cracks to get through veins that are refluxing. So I would inject it as distal as possible, and it's a very neat thing to see. You see the medicine track up using ultrasound, and you can actually see it getting into those refluxing segments. And so my closure rates improved significantly in patients that came back with recurrent symptoms and recanalization. So that's where it really started to become very prominent in my practice. And then I said, you know what, I have to invest some time in education in my staff, because I want them to understand what this modality is, why we're using it, and in what patients this will benefit most. And so they started to become more excited because they see these patients coming back feeling better. These are patients, again, that are having recurrence of symptoms, and in the past we just didn't have a whole lot we can offer them other than physician compounded foam. But we can also understand with physician compounded foam, the closure rates are not as good because of the lack of the concentration being adequate to get those veins, those large bore veins, to close. So recanalized veins became a very interesting subset of patients for us to use Varithena in, and we were very successful with that. Then we started thinking about those patients that have C6 disease, those patients that have recurrent venous leg ulcers. And if you do enough of these, you start to realize that there's typically pooling of blood from years and years in those refluxing tributaries that are at the base of the ulcer that do not allow that leg ulcer to heal. And obviously this can be a huge issue for the patient socially, financially. It drains the hospital systems. We know that it's a huge cost in the healthcare. It's a huge burden, the healthcare cost. And so we thought about using this, again, liquid property in being able to inject those tributaries that are refluxing at the base of the ulcer. As you can imagine, this can be somewhat painful for the patient, but I will tell you that when we offer this to patients, they're just so tired and fed up of having this ulcer. They say, just please fix it. I don't care if you have to put a needle at the base of the ulcer. I know it might be painful, but if you can get medication into a vein and you're telling me that you can heal it so that my ulcer improves, then I'm all for it. And I think that's where the education component of that comes into play. It's important to educate our patients. Our patients look to us as clinicians to offer them the guidance. And so during my consultation, what I'll do is I'll sit down with the patients and I'll tell them all the modalities that exist. And when I want to use Varithena, I'll go into further depth about Varithena and why I think it's beneficial, and particularly in those patients that have those ulcerations. And at the end of the consultation, despite them knowing that it might be a needle stick into the base of the ulcer, they're okay with going forth with doing this. As we know, Varithena is indicated in the great saphenous vein and tributaries that are coming off the great saphenous vein. So many times these patients have these tributaries that are refluxing. The great saphenous vein has been closed, whether it's a thermal modality or non-thermal modality, but we know that once you close that axial vein, not all refluxing tributaries close. And if you still have that recurrent reflux there, that ulcer is not going to heal. So what we can do is, again, use the liquid property of Varithena. We inject the Varithena as distal as possible. You watch the medication go up, and then you can proximally compress. And you can then watch that medicine hit resistance and then start to feed into the refluxing tributaries. It's a very neat thing to see under ultrasound. And as that liquid foam starts to make its way into the tributaries, you can start seeing the base tributaries at the base of the ulceration start to fill. And it's typically kind of like that hyperechoic white bubbly look. At that point, patients will typically feel some type of discomfort. Typically it's burning. And that burning, I tell them it's a good burner. It means that the medication is working. And that offers them some confidence. So again, I think that those patients that have leg ulcers are very, very good candidates for Varithena because, again, you can get that liquid right into those refluxing tributaries at the base of the ulcer. I say Varithena goes where no other modality can go at this point in the superficial vein space. And so why not utilize that as an advantage for our patients? So once we became more comfortable and we started seeing these leg ulcers healing faster, the wound care centers were calling us and saying, what are you guys doing? These ulcers are healing way faster than what we're used to. And again, that was another aha moment for me in that this compound is very good, it works, it's very effective, and it offers patient satisfaction. At the end of the day, we come to work to help our patients. And if we have satisfied patients, we understand that satisfied patients go out and tell 5 other people in their community or in their families. And so that's how you build your practice. I always say, I don't need billboards. Our patients are our billboards. They're the ones that go out and vouch for us and say, look, I had all these symptoms, but this doctor was able to treat me and make me feel better. If you're having these symptoms, they become your biggest fans. So that's why I like Varithena in that patient subset of venous leg ulcers, because again, it's very gratifying, they do quite well, and they just are so desperate to get this ulcer to heal. As we became more skilled and more comfortable, the next question was, well, we're using it distally in the calf segment, why not start using Varithena in the proximal thigh segment? And I thought about it, and I will be honest, I was hesitant initially to utilize it in the thigh compartment simply because of the fact that I had a phobia that the medication may travel up and go into the saphenofemoral junction and thereby create a deep vein thrombosis if I'm not careful. My other concern was that if I inject the medication, albeit if I inject it slowly, some of the medication can still shoot up and get into the deep system that I may miss. These are all phobias that I had. So once I looked into the data, the VANISH-1 and VANISH-2 trials, I looked at the patient subsets that were involved, and I saw that GSVs were included in the proximal segment reflux. So GSVs that were refluxing in the proximal segment were included in these trials. And I said to myself, well, what about diameter, right? Because we're all concerned about the larger GSVs. And it's important to know that the largest diameter GSVs that were included in VANISH-1 and VANISH-2 were upwards of 25.9 millimeters, which is a quite large diameter for a great saphenous vein, I must say. This gave me added confidence that this has been studied in the proximal thigh segment, particularly including larger diameter GSVs, so why not give this a try? So at that point, I decided to start treating a full refluxing great saphenous vein with Varithena. And this is where I think my learning curve went up, and this is where I made a lot of my mistakes. The first mistake that I made was when I started accessing the great saphenous vein. If it was refluxing in its entirety, I would access the distalmost ankle point. At that point, then, I would go ahead and I would start injecting Varithena through a needle. As I injected the Varithena, I would watch it make its way up. What I learned is that whether you inject 8 cc's or 10 cc's, or we know the IFU limit is 15 cc's, whatever it was, by the time the medication was making its way into the thigh segment, what I noticed is that when I followed these patients back, the closure rates were not very good, particularly in the proximal thigh. And so when we thought about it, if you think about injecting a medication like Varithena, the potency is highest at the injection point. As the medicine is making its way up the vein, the medicine is doing its job. It's attaching to the wall of the vein, causing the vein to contract and close down. But we should not expect that that potency will be the same in the calf and in the thigh if you're injecting the distalmost point. So I adapted my approach to administering Varithena by accessing the distal thigh segment and the distal calf segment separately. I accessed the distal thigh segment first, and I would use a sheath. It's very important to do this when injecting the great saphenous vein. And when I say use a sheath, I don't mean a large sheath. You can use a 4 French, a 5 French, even a 6 French. But in my practice, I like to use a 5 French sheath because it gives me rigidity and it doesn't create a large hole. Stability of access is essential when you're administering Varithena. Why? Because if you put a needle in the vein and then you move the patient, or the patient moves unbeknownst to you, that needle can dislodge from the lumen. If the needle dislodges from the lumen and you're not aware of this, what potentially can happen is you may inject the Varithena subcutaneously, obviously causing a lot of pain to the patient. So stability of access is very important. That's why I like putting a sheath in. This way, once you put a sheath in, you can elevate the leg. You usually want to elevate the leg for at least 3 minutes. 3 to 5 minutes is my zone of elevation. Boston Scientific provides a very nice wedge that our patients love. Many patients ask me if they can take the wedge home. That's how comfortable it is. So it's important to wedge that patient for at least 3 minutes to drain that great saphenous vein. Once you drain that great saphenous vein, you will notice that the vein has shrunk. That's why it's important to access the great saphenous vein before you elevate, because it can make accessing difficult afterwards. So once you access, you put your sheath in, you elevate the leg for 3 to 5 minutes. You then can go ahead and administer the Varithena into the great saphenous vein. What you can also do while you're waiting during those 3 to 5 minutes is you or your vascular tech can confirm if there's any perforators along the way. Perforator mapping is very important, and it's okay to check twice. I always say you can never check enough. So what I do is I then double check everything while I'm waiting those 3 to 5 minutes. If I find any additional perforators, I will mark them. So that this way I know that I want to compress that perforator as the medication is making its way up. So once we've done this, we then go ahead and we have the canister ready. And I always say, don't pull the medication out until you're ready to administer it, because you don't want the medication to be just sitting on the counter. It's no need for that. So we then use the syringe, we go ahead and purge, and then get our Varithena into the syringe and then inject through the sheath. I always say that it's not a race to inject the medication through the sheath. You want to take your time. Usually I would say a cc every 1 to 2 seconds is okay. As you're injecting the medicine is not going to shoot up. The medicine actually has a very nice leading edge that makes its way up the great saphenous vein, so you can actually follow that with the ultrasound. You may want to have somebody's hand just gently compressing the saphenofemoral junction. Do not compress it too hard. If you compress the saphenofemoral junction too hard, what you may do is you may create an unnecessary column of resistance in that as you're trying to inject the medicine distally and you're compressing proximally, the medicine may not want to make its way up because of that column of resistance. So make sure you let up, and also then with the ultrasound probe, watch the medicine track up the great saphenous vein. Once you get to the point of 2 to 5 centimeters below the junction, you go ahead and then compress, and you just watch the medicine leading edge sit there. It's very, very nice. I always get an ultrasound image of that because it's neat to show. And again, you want to compress for at least 3 minutes. You want to take your time. You don't want to rush that part, because if you do, then you might get medication to seep in through the saphenofemoral junction and potentially have a DVT. So patience is important. Patient selection is important. Patient setup is very important. Once you've injected, I usually inject about 5 to cc's in the thigh compartment. You then go ahead and inject an additional 4 to 5 cc's from the distal calf compartment. So if you want to get access in the distal calf at the same time of getting access in the distal thigh, I would highly suggest that. This way you have 2 access points already set up for you. So once you finish injecting in the distal thigh, you can then go ahead and additionally inject another 4 to 5 cc's from the distal calf. I usually give about 10 to 12 cc's in the entire GSV, but it's variable by physician and patients. So once I inject the entire amount of medication, I then pull the sheets out, and then I just compress very gently. Varithena comes with a very nice pack of Robbie pads that are cylindrical pads. I highly suggest that you use them. What you do is you put those right on the area of the great saphenous vein. They provide very nice focal compression to the area. I also suggest that you use 4x4 pads. Put 4x4 gauzes on the skin prior to putting the Robbie pad on. Otherwise, you may have blistering on the skin. This is something that I've learned from practice. You may be asking yourself, why do I inject the Varithena in the distal thigh segment first and then the distal calf segment second? Well, the idea is, from my standpoint, very simple. When you inject Varithena and you're watching it make its way up the great saphenous vein, you will see the vein start to spasm. And as that vein is spasming, that's a good sign. That means that the medication is working. So once you've finished injecting the thigh column of the great saphenous vein, you can imagine that after 3 to 5 minutes, that vein is pretty spasmed down. So when you go to inject in the distal calf, as that medication is making its way up, you're not going to worry about much of it getting into the thigh segment because that area is already going to be spasmed down. You can hold a little pressure at the knee, but you don't have to be worried about a lot of that medicine seeping up and thereby having more of the medication hanging out in the calf compartment where you want that vein to close as well. So if you do these steps, your vein closure will improve significantly with the great saphenous vein. Again, I've used Varithena in the great saphenous vein proximally through the distal segments, and the closure rates have been fantastic in my practice. But again, it was a learning curve. And these steps that I've shared with you are very important along the way, especially when you're administering the Varithena in the great saphenous vein. Varithena has impacted my practice in many ways, but one of the most important ways has been increasing not only the efficiency, but my patient satisfaction. When I'm doing a consultation with a patient and I'm talking to them about the disease process, and I tell them that, they would be a good candidate for having a vein closure procedure, sometimes a look of horror comes on their face. And I say, listen, this is not life-threatening, but if this is bothering you and this is limiting you in your lifestyle, we can certainly help you. Their next question typically is it going to hurt? And how many needle sticks am I going to get? And I think that that can sometimes, unfortunately, be the decisive factor between a patient getting the procedure done and not getting it done. So if I can look them in the eye and say, listen, I can treat your entire great saphenous vein with 1 to 2 needle sticks. I think I'll have a buy-in versus saying, well, I'm probably going to have to stick it 6 to 10 times up and down, giving you between the anesthesia and the access. And so I think patients moving forth with getting the procedure done has increased in my practice, again, just simply because the fact that it's less needle sticks. Efficiency has increased in my practice after using Varithena. Once you become proficient in it, is way less than the amount of time allotted towards using thermal tumescent modalities. If you think about it, with thermal tumescent modalities, you have to prep the patient, have everything sterilely set up, and then administer the tumescent and all that stuff that comes along the way. So efficiency has increased, which allows me to do more cases during the day. The other thing that I've noticed with using Varithena in my practice is patient satisfaction has improved. Many times after finishing a Varithena case, the patient looks up surprisingly and says, "That's it? Are you joking, doctor? This is the procedure?" And it's very, very funny. It's almost like they're assuming that it's going to be this huge, drawn out procedure, especially when they start reading about it or they go on the internet and do their research. But it's gratifying for me because that means to me that it wasn't painful and they were expecting it to be a lot worse than it actually was. Many times, patients that have chronic venous insufficiency do not just have it in one leg. Most of the time, they have it in both legs. And so if you can imagine having a patient come in that needs the ablation procedure performed, and you do a procedure on one leg and they did not have a good experience, whether it was too many needle sticks, they didn't like the tumescence, it was painful for them, they didn't like the pressure, whatever it may be, then the likelihood of them coming back for the other leg may not be as high, or they may think twice about it. With Varithena, what I've noticed is I've had patient retention improve. I've had patients come back to get their subsequent procedures because, again, they know that what to expect now is not as worse. They know that what to expect is nowhere near as bad as they thought it was going to be. So they come in way more relaxed. They come in understanding that this is just like almost getting an IV, or it's like getting a blood draw. And it becomes more comfortable for the patient. And our staff also enjoys the patient satisfaction. The patients oftentimes on follow-up will share with them how they're feeling much better after the Varithena case, and not to mention sometimes the cosmetic benefit that comes from Varithena. Everybody is not vain about their veins, but at the end of the day, the cosmetic benefit is certainly the icing on the cake, especially for those that have spider veins. So we also enjoy when patients come back and say, not only do my legs feel better, but they also look better now. So that's quite gratifying, especially when using Varithena in these cases. When we practice medicine, we have to understand that this is a team-oriented approach. Medicine is not only administered from the clinician, medicine is a team sport. And so when the patient comes to our practice, I always say that they will remember the first person they saw walking in and the last person they saw walking out. And so that's typically our staff members. And so staff retention is important, staff satisfaction is important, team spirit is also very important. And so what I've noticed when using Varithena is the ease of setup also makes the day more comfortable for our staff. Setting up Varithena, again, is not taxing when compared to setting up for thermal tumescent anesthesia. You don't have to worry about loading up cath packs, opening up cath packs. You don't have to worry about making tumescent anesthesia in the morning or making it during the case, because again, that all requires time and effort. When you're using Varithena, you have a canister, you have the pack, the administrative pack set up, and you have a chuck, and you have the wedge. And once your staff becomes proficient with Varithena, it's a very, very simple setup. So they enjoy it because it gives them less time to having to set up for the case, and more time being able to be with the patient, more time being able to set up and plan for the next case. And let's be honest here. Sometimes, it's good to have some downtime for the staff. They can grab a cup of coffee, or they can make a quick phone call. So it's also important. Staff satisfaction is equally as important in my practice as much as patient satisfaction. Because if I don't have a happy, competent staff, then I'm not going to have happy patients. And I certainly won't be happy as well. What I would tell a physician who wants to start utilizing Varithena in their practice, but is hesitant or is nervous about using it because of a potential increase in DVTs, is that they're being nervous for no reason. I've been using Varithena for about 5 years now, and I say that if you never get a tibial vein DVT, you just haven't done enough procedures. Most of the DVTs that come in our practice, if they get a DVT after Varithena, is in the tibial vein. And as you know, tibial vein DVTs tend to be indolent. In my practice, if a patient presents with a tibial vein DVT after Varithena administration, we usually pick that up at the 1 week mark when we bring them back. The first question I ask them is, are they symptomatic or not? Because if they're symptomatic, then treatment is important, and I follow the American College of Chest Physicians guidelines for that. So if they come back and they have a tibial vein DVT and they're symptomatic, I usually put them on a low-dose 81 milligram aspirin once a day if they can handle that. If they're already taking aspirin and they're symptomatic, then I add a direct oral anticoagulant of your choice. If the patient comes back at 1 week and they're found to have a tibial vein DVT and they're asymptomatic, then I may just follow them with surveillance ultrasounds every 2 weeks or so. The ACCP guidelines also say if a patient is asymptomatic with the tibial vein DVT, you may do surveillance ultrasound, or if it makes you more comfortable, you can put them on a low-dose aspirin and bring them back at 2 weeks. I think education is very important when we're doing our patient consultations. And one of the things that I speak about to my patients when I'm talking about the procedures is some of the adverse events that can occur. I think that it's important to communicate effectively with our patients. So most of my patients come mentally prepared to understand that there is a small risk of developing a blood clot after these procedures. Varithena is no different. If you administer Varithena effectively and you look at the perforators and you compress the perforators, the likelihood of developing a tibial vein DVT is low. But what I say is that if you have done enough Varithena cases, you will get a tibial vein DVT every now and then. You should not be worried about that. You should not be overly alarmed about it. My first question typically to that patient that develops a tibial vein DVT is, are they symptomatic or not? If they are symptomatic, I will go ahead and start them on a low-dose 81 milligram aspirin. If they're asymptomatic, I can do two things. I can either still start them on a low-dose 81 milligram aspirin, or I can do ultrasound surveillance and bring them back every 2 weeks or so. In the VANISH trials, one of the most common adverse outcomes was retained coagulum. So I always say that with retained coagulum, that means that the medication is doing its job. And so what I do is, in order to decrease the amount of retained coagulum, I drain the vein ahead of time. If there's a vein that is engorged or if there's a varicosity there, I will go ahead and drain the vein ahead of time. Once the vein is drained and decreased the amount of pressure in that vein, there's less blood that hangs around and thereby less retained coagulum. Thereby, by having less retained coagulum, you're not going to have patients that come back with pain or discomfort. So what I do again is I drain the vein ahead of time, and then I like to inject the Varithena afterwards because I know exactly where the medication is going and I can control and compress it. One of the other questions that comes about is the incidence of DVTs in the trials, the VANISH 1 and VANISH 2 trials. But if you look at the data, majority of these DVTs were tibial vein DVTs, and roughly half of them resolved on their own without any treatment. If you look at the data closely, less than 1% of the DVTs were proximal and symptomatic. So I say to my colleagues, why are you worrying about something that can occur less than 1%? And yes, if you get a tibial vein DVT, it doesn't mean you're a bad physician. It doesn't mean you're a bad clinician. It just means that the medicine was doing its job and some of it may have gotten into a perforator. It's not the end of the world. The patients will do well. It's all about catching this in time, and that's why we bring them back at 1 week. The other learning lesson for me was patient follow-up. and looking at vein closure rates. When I first started using Varithena, I would bring them back at 1 week to check for DVTs, and I also would check for vein closure. And what I found every now and then was that the vascular tech would come to me and say, "Hey doc, the Varithena didn't work." And I said, "What do you mean?" And they said, "Well, there's no blood clots, but the vein is wide open." And I obviously would become disappointed, and then I would think maybe the Varithena is not the right choice for a patient. So when I looked at the data, what I found was that vein closure rates actually were looked at 30 days and after. So I changed my follow-up protocol. So now that when I use Varithena in a patient, I will still bring them back at the 1 week mark to check for DVTs, but after that, I bring them at 30 days to check for vein closure. So if you check for vein closure at 1 week, your closure rates may be falsely decreased. So wait at least 30 days to check for vein closure after Varithena. Oftentimes the question arises, when do you use Varithena and when do you not use Varithena? I think Varithena is the most versatile treatment modality we have in the superficial vein space. And so I like Varithena because it gets into the tortuous veins, it gets into recanalized veins, it gets into the veins that are refluxing in the distal segments where you're worried about thermal injury. So if it was up to me, I would use Varithena in a majority of my cases. Unfortunately, we also have to make sure that we're following the insurance guidelines. So I always say, know your local care determinant factors. Boston Scientific has very good resources for that, and I encourage you to reach out to them for these resources. Where I tend not to use Varithena is in those patients that have multiple large perforators. In my practice, the definition of a large perforator is more than 3 millimeters. So if I have more than 3 perforators along the great saphenous vein that are larger than 3 millimeters, and I feel that I might lose a lot of that medication into the deep system through the perforator, then I would shy away from using Varithena in those cases. The only other case where I can think of not using Varithena would be somebody who is not compliant with compression. Compression after the case is very important, and that comes with the education during the consult. The patient should wear the compression wrap after the procedure and then wear stockings thereafter for at least 2 weeks. Those are the 2 scenarios where I think I would not use Varithena. Oftentimes, people say, "What's the big deal about Varithena?" It's the same thing as physician compounded foam. And I've learned in my practice that that is completely false. Varithena has better closure rates when compared to physician compounded foam. And as I have studied this more and more, it ultimately comes down to the uniformity of the bubbles. The proprietary canister system that is provided by Boston Scientific to administer Varithena makes care to deliver a foam that has uniform bubbles. The uniformity of the bubbles then translates into stability of the compound. The more uniform the bubbles, the more stable the compound, the better the wall contact of the medication, thereby having better closure rates of your veins. And so that is the major difference between physician compounded foam and Varithena. Physician compounded foam does not produce uniform bubbles and does not produce the same stability of compound of polydocanol that the proprietary canister does. If I can think of one word that Varithena has provided to my practice, it's versatility. It gives me the ability to treat a whole gamut of patients, a wide spectrum from C2 to C6. It also allows me to be versatile in treating different modalities within the superficial vein space, whether it's an active ulcer, whether it's a recanalized great saphenous vein, or whether it's somebody who has symptoms with some cosmetic concern. So Varithena has certainly brought improved versatility to my practice.